Good morning, everyone. Thank you for your attendance and for giving me an opportunity to be part of this grand round. I decided to title my presentation as Venous Thromboembolisms in Pregnancy, Guideline-Oriented Enlightenment. In fact, all the presentation would be based on ESC guidelines published in 2018. So my outline is simple. It's all about 6 questions. Venous thromboembolisms in pregnancy. First of all, how common are they? Second, who is at risk? What category of pregnant patients is at risk? The third question is how to prevent. What is the prophylaxis technique? The fourth and fifth questions are how to manage, whether it's an acute PE or on the long term, or an acute DVT or on the long term, and then how to manage pregnant women in delivery when they are anticoagulated. First question, how common? Most of you would think that venous thromboembolisms are not very common in pregnancy. In fact, they are not very common and they are not uncommon as well. It's a fair number. 0.2% is the prevalence of venous thromboembolisms in pregnancy. And in fact, when this venous thromboembolism is a PE, the fatality rate is not low as well. It is 3.5%. Now, venous thromboembolisms are not equally distributed over the timeline of pregnancy. They are not as common in the first trimester as in the second or the third. In fact, the peak incidence is at the third trimester, at the end of the third trimester, which is near labor, and in the few weeks postpartum, then it decreases until the 6th week postpartum. As we see here, near the third trimester, the incidence rises. It reaches a peak peripartum, near birth, near delivery, and then it drops thereafter. So this is the area and the timeline where we need to be very high in clinical suspicion. Women with a previous venous thromboembolism rate, in fact, these have a very high rate of recurrence, up to 7.5%. And even women categorized as high-risk patients, they have a 5.5% risk of venous thromboembolism. So 2 categories to shed light on: those who previously had a venous thromboembolism and those categorized as high risk. Who is at risk? Are all pregnant women at risk? In fact, pregnancy poses a risk of increasing venous thromboembolism, but not all pregnant women are equally at risk. I will set here a bunch of risk factors, then I will tell you how we will use them in categories and how will they be beneficial. These risk factors are not unexpected. In fact, it's very expected that increasing age, BMI, or parity would increase the risk of venous thromboembolisms. Of course, smoking status, elective cesarean, not cesarean in labor, because this is another type of risk factor. Family history of venous thromboembolism, low-risk thrombophilias, immobility, current infections, etc., preterm delivery. So these are a bunch of risk factors. How to use them in practice? In fact, a study published in the GACC based these risk factors and categorized patients into either low risk, intermediate risk, or high risk. Any pregnant woman who had less than 3 risk factors of those mentioned in the previous slide are considered low risk patients. Those who have 3 or more risk factors are considered intermediate risk patients, or those having a single one of these: cesarean section in labor, massive obesity, any surgical procedure required, or another comorbidity that increases the risk significantly, like heart failure, cancer, lupus, etc. We need really to shed light on this third category because it is the one of concern. High-risk patients are one of 3. Either those who had a previous venous thromboembolism, we've already mentioned they have a recurrence rate of 7.5%. Those requiring antenatal low molecular weight heparin for any reason, or those with high-risk thrombophilia, such as those inherited ones that have a particularly high risk for venous thromboembolism. So it's fine now. We know how prevalent it is. We know which category is at risk and how to categorize the patients. The third question is, now I know my patient is high risk, for example. How can I prevent it? Is there a way to prevent venous thromboembolisms? The answer is very simple, and it is a very simple drug. We all are familiar with the low molecular weight heparin is the drug of choice. Some would ask, is there an alternative to low molecular weight heparin? Studies, in fact, have put low molecular weight heparin with the heparin itself on long-term studies. Low molecular weight heparin was better in less bone loss, less osteoporotic fractures. Moreover, low molecular weight heparin is easier than heparin to take as subcutaneous injections. Pregnant women that took low molecular weight heparin had much less rate of venous thromboembolisms and pulmonary embolisms compared to heparin. So low molecular weight heparin was the golden drug of choice. Is it a standard dose to be taken? Most of us memorize the standard dose, 40 milligrams sub-Q once daily. In fact, studies have proven weight-based dose, half milligram per kilo. Average بيطلع 40, إذا قلنا average الwomen are 80. But in fact, the female should weigh herself عند الجينيكولوجيست تاعها at the 10th week, اللي هي first visit. And then it's a weight-based dose, half milligram per kilogram once daily. Okay, so we have known which patients are at risk. We have known the prevalence. We have known a high-risk patient. We've tried to prevent it, but we could not prevent it. The case occurred, and the patient presents with acute PE or acute DVT. We will start with the acute PE. How would we manage? A key point in acute PE is that we never wait confirmation of the diagnosis to start anticoagulation. إذا في single take home message ناخدها كلنا إنه acute venous thromboembolisms, whether PE or DVT, you never await to ensure the diagnosis to start anticoagulation. Once you have high clinical suspicion, anticoagulation should start independent of your plan of diagnosis. So once you have high clinical suspicion, you should start therapeutic anticoagulation. So clinical prediction rules that are accepted in the general population have never been verified in a pregnant woman. So none of the scores or the plans provided previously are accepted in a pregnant woman's. But a high index of suspicion is the key. Once you have that, you should start therapeutic anticoagulation immediately until diagnosis. الدي دايمر هيستوريكلي معروف قد ايه له رول بالفينس ثرومبومبوليزمز. بالبريجنسي هل له رول؟ عندنا تو كونفاوندينج فاكتور، انه الدي دايمر لحاله بيعلى ان بريجنسي من ترايمستر لترايمستر بنسبه 39%. So a positive D dimer cannot confirm venous thromboembolism because it will be elevated anyways. Another thing is a normal D dimer does not exclude venous thromboembolism in a pregnancy because a study showed that some pregnant women having venous thromboembolisms had a normal D dimer. So what to do? Studies have proposed a modified Wells score and the D-dimer combination only to stratify, not to diagnose the patients, but followed by that, the key is a compression ultrasound. Yes, we are talking about PE, and the key is a compression ultrasound, because if you have caught the DVT in the peripheral veins, then you can assume that this clinical presentation and the appropriate clinical scenario is a pulmonary embolism. الهدف نبعد من الراديation بالinitial algorithm, so I should start with a compression ultrasound for the veins. One would say this would miss some DVTs in the pelvic veins, in the iliac veins. That is why, if negative, I should follow it by a venous magnetic resonance imaging. If both of these are negative and we still have a high clinical suspicion for a PE, والله ما بين بالperiphery but I'm still suspecting PE, هون the guidelines propose a low dose CT pulmonary angio. I know many of you would have expected VQ mismatching with scanning بنحكى عنها, but the guidelines still put a low dose CT scan ahead of a VQ scan in ruling out pulmonary embolism after compression ultrasound and MRI are negative and the clinical suspicion is high. Okay, that we diagnosed either by compression ultrasound in the appropriate clinical settings or by a low-dose CT, and now we need to treat. Still the same golden drug of choice for prophylaxis is the treatment. Low molecular weight heparin is preferred in a pregnant woman with venous thromboembolism. Of course, the dose should be different. It is not 0.5 milligram per kilo. It is 1 milligram per kilo twice daily. Okay, other low molecular weight heparin are present as well. An important thing is that we should follow the anti-10A level because it's therapeutic, it indicates being in the therapeutic range. باللوفينوكس ما عندنا follow up of PTT مثل therapeutic heparin. We follow the values of anti-10A and they should be between 0.6 and 1.2 at a peak level 4 to 6 hours after administration. Can someone use unfractionated heparin? Of course, it could be the drug of choice, especially in acute massive PEs. In fact, thrombolysis is the drug of choice with heparin in massive pulmonary embolism inducing hypotension or shock, life-threatening PE. But when we give thrombolysis, we all know the unfractionated heparin loading dose should be omitted, and we only stay on the maintenance dose or the syringe pump dose at 18 units per kilogram. One would ask, is fondaparinux recommended? It should only be taken if there is a contraindication to heparin مثل HIT أو إلى آخره أو an allergy to heparin or low molecular weight heparin. في دور للIVC filters only in extreme cases, only when all other anticoagulation are contraindicated مثل بالmassive hemorrhage أو unparalleled PE مع مثلا intracranial hemorrhage. Only we go towards an IVC filter to prevent. We started the anticoagulation. Shall we continue anticoagulation postpartum? So after a recent PE, of course, anticoagulation should continue postpartum. For vaginal birth, heparin can be restarted 6 hours postpartum, and for cesarean delivery, 12 hours postpartum. Then we should bridge with warfarin, with vitamin K antagonists, at least for 5 days, and we stay in therapeutic anticoagulation for either 3 months or 6 months if the PE occurred late in a pregnancy. The INR target, of course, between 2 and 3. An important question is, are vitamin K antagonists taken postpartum safe for breastfeeding? Yes, they are, and no active molecules cross into the breast milk. So we manage PE acutely. How do we manage DVT acutely? The algorithm does not differ a lot, but the clinical presentation is nice. Leg swelling is common, but it is also common in pregnancy as well. So the suspicion here is, the case is a bit suspicious. A nice important anatomical note is that in pregnancy, left-sided DVTs are more than 85%. Prevalence كتير بيختلف بين left to right عند the pregnant woman. A simple anatomical cause behind it is that the left iliac vein is compressed by the gravid uterus. So expected يعمل more DVTs. وإذا كانت proximal بالإلياك part ممكن تجي بس abdominal pain أو buttock pain أو flank pain. حطوا 3 clinical variables in a study, and they found out if none of these is present, 99% it's not a DVT عند the pregnant woman اللي هن left leg presentation, more than 2 centimeter circumference difference at the calf, and first trimester onset. If all these 3 are negative, 99% this pregnant woman is not having a DVT. It's simply due to pregnancy or another cause. But still the same, the golden imaging to start with is compression ultrasound. دايما بنبعد عن radiation بالinitial algorithm لأنه هن pregnant trying to go into less radiation. If the compression ultrasound is negative and I'm still suspicious, I should go into an MRV, magnetic resonance imaging for the venous system. It is essential in this case. In fact, for the ultrasound, there was a timeline proposed called 037 at day 0, at day 3, and at day 7. This combination results in 99% negative predictive value. So what should I do? Let's say, let's consider a scenario, a pregnant woman, and we have a high clinical suspicion for DVT. We started with a compression ultrasound together with D-dimer and some other labs. The compression ultrasound is negative. Should I continue anticoagulation or stop? We start on high clinical suspicion. The answer is, if your clinical suspicion is still high, you should continue. If it is low, you should stop. But anyways, you need to repeat your compression ultrasound at day 3 and at day 7, and every day the same thing. If your clinical suspicion is still high, you should continue. If now it is low, you should stop. When you finish your 7th day, even if your clinical suspicion is still high, but all of these are negative, together with an MRV for the pelvic veins, it is not a DVT. حتى لو كان ساعتها clinical suspicion high, بيكون غلط clinical suspicion. So anticoagulation should continue until either the imaging rules out this DVT or your clinical suspicion fades. بيبقى الانتيكواجيليشن لوحدة منهم. Okay, this is the thing I was explaining. So the initial compression ultrasound, if it is negative, I should go for an MRV. If both are negative but the clinical suspicion is high, continue your anticoagulation. اعتبرها DVT until you rule it out at day 3 and day 7. If your clinical suspicion now fades, stop your anticoagulation, but take your ultrasound at day 3 and 7 anyways. Treatment does not matter a lot. Venous is the drug of choice. Other options are present. In acute DVT, you should also go for therapeutic low molecular weight heparin, and continuing postpartum is the same as in PE. Now, we have known the prevalence of DVTs and PE. We have known how common are they, what are the risk factors, which females pregnant are in danger, how to prevent it, and if it occurred, how to treat it and diagnose it, whether it was a PE or a DVT. Now, the phase in between that we didn't talk about. A patient was diagnosed with DVT or PE and was on therapeutic anticoagulation and presented for labor, or was to be scheduled for labor. How to manage part labor with my anticoagulation. First of all pregnant women on anticoagulation should be planned for delivery at 39 weeks. لأنه we need to avoid the spontaneous labor while on low molecular weight heparin, as this increases the risk for the pregnant woman and her fetus or her child of bleeding, and Lovenox is only partially reversed by protamine sulfate. يعني ما عندنا plan B إذا صار في spontaneous labor. The second thing is I should categorize my patients as either high risk or low risk. If my patients are high risk, I need to keep them anticoagulated as much as possible. يعني حتى الساعة بدي اكسبها. So I cannot stop this Lovenox like 1 day or 2 days before. No, I should continue Lovenox and shift to heparin only 36 hours before delivery. لأنه الهيبارين has shorter half-life. And continue on heparin only until 4 to 6 hours before delivery. I stop my heparin. I take my PTT and guide my anesthesiologist. Once the PTT is fine, my anesthesiologist can go into the procedure, and 4 to 6 hours after the procedure, heparin can be resumed, or 12 hours إذا كانت cesarean. طب إذا البيشنت لو ريسك والله وما عندنا مشكل تبقى نهار كامل بلا أنتي كواجيليشن، تختلف الموضوع، ما بنعقدها هالقد. We only miss the evening dose of the Lovenox. ساعتها نهار الدليفري بيكون صار لها 24 hours of anticoagulation and she is low risk, so it's fine. She goes into delivery and then we resume it postpartum. These are the recommendations I've based my presentation on. These are driven from the ESC guidelines 2019, and I thank you very much.